Hey everyone, and welcome. Today, we are going to build up your professional GI vocabulary. So, whether you're a student getting ready for clinicals or you just want to make sense of all the medical jargon, you are definitely in the right place. We're about to cover the absolute essential terms for gastrointestinal health. So, let's start with this question. What language do we actually use to talk about gut health? And, that is such a critical question. Because in healthcare, using precise language isn't just about sounding smart. It's about communicating clearly, charting accurately, and at the end of the day, giving our patients better care. So let's build that vocabulary together. Okay, so we've broken this down into 5 really logical chunks. We'll kick things off with the basics of the GI system, then we'll get into some common problems. After that, we'll look at diagnostic tests, then treatments, and we'll finish up with some specialized surgical care. Trust me, following this roadmap is going to make these terms so much easier to remember. All right, let's dive right into Section 1, GI System Basics. Look, before we can even think about what goes wrong, we've got to understand the fundamentals of how the system is supposed to work in the first place. These are the building blocks. First up is chyme. You can kind of think of this as the star of the whole show. It's that soupy, acidic mix of partially digested food that leaves the stomach and enters the small intestine. Pretty much everything we're about to talk about, absorption, making waste, getting rid of it, it all happens to chyme. Basically, our entire GI tract is designed to process this stuff. Next, here's a term we all know, flatulence. It's just gas building up in the digestive tract, plain and simple. And while it's totally normal, a major change in a patient's flatulence can actually be a really key clinical sign for a lot of the issues we're about to get into. Okay, so now that we've got those basics down, let's build on that and move to Section 2, common bowel problems. This is the vocabulary you're going to need for when that whole digestive process hits a snag. Here we've got 2 sides of the very same coin, constipation and diarrhea. The 2 words you need to remember here are frequency and consistency. Constipation, that means bowel movements are infrequent and the stool is hard and tough to pass. Diarrhea is the exact opposite, frequent, loose, watery stools. The definitions are simple, but these are 2 of the most common complaints you will ever hear from patients. And this slide digs a little deeper with 4 more super important terms. First, there's impaction. Think of this as severe constipation that's gone on for too long, where a hard mass of stool literally gets stuck. Next up is ileus, which is totally different. That's when the intestines just temporarily stop moving. Then you have incontinence, which is the loss of bowel control. And finally, a hemorrhoid, which is a swollen vein down in the lower rectum. 4 very different problems, all crucial to get right. Now for a really specific infectious cause, Clostridium difficile, or as you'll always hear it, C. diff. You have got to know this bacterium because it's a major cause of severe diarrhea, especially for patients who've just finished a round of antibiotics. It's a powerful reminder that we have to look for the cause of the symptom, not just treat the symptom itself. So, a patient comes in with a problem. How in the world do we figure out what's causing it? Well, that brings us right to our 3rd section, diagnostic tests and procedures. This is all about being a detective, the fact-finding part of GI care. The headliner of GI diagnostics has got to be the colonoscopy. It's what's called an endoscopic procedure, which just means a flexible tube with a tiny camera on the end. The colonoscope is used to get a direct live video feed from inside the large intestine. It's a huge deal because it works as both a screening tool and a diagnostic procedure. So why do one? What are doctors looking for when they do a colonoscopy? It's a great question because the answer leads us perfectly to our very next key term. And here is a huge part of the answer, polyps. These are abnormal little growths on the inside lining of the colon. Now, most of them are harmless, but some types can actually turn into cancer over time. So finding and removing polyps during a colonoscopy is an absolutely critical preventative measure. Now, before someone even gets to a colonoscopy, they might do one of these less invasive screenings. We have the FOBT, or fecal occult blood test, and the FIT, the fecal immunochemical test. Both of them are designed to find occult blood, and occult just means hidden, in the stool. You can think of them as giving us the initial clues that tell us if we need to take a closer look with a colonoscopy. All right, once we have a diagnosis, what can be done? Let's talk about interventions. Section 4 is all about the vocabulary of treatments and all the strategies we have for managing GI issues. An enema is a procedure where fluid is introduced into the lower bowel. This might be done for a couple of different reasons, maybe to relieve some really bad constipation,
to clean out the bowel before a procedure like a colonoscopy, or even to give medication directly into the colon.
Now, what's really interesting here is the subtle difference between laxatives and cathartics. I mean, they're both used to get the bowels moving, but they are worlds apart in intensity. Laxatives are generally milder. They soften the stool and make it easier to pass. Cathartics, well, they're the heavy-duty version. They are much, much stronger, and they speed up defecation in a big way. It's a really key difference in treatment intensity.
And check this out. Here's a treatment that isn't a drug or a procedure at all: bowel training. This is a behavioral program. It's all about helping patients set up a regular schedule for going to the bathroom, using the body's own natural reflexes to help manage long-term constipation or incontinence. It's just a brilliant example of a more holistic way to provide care. For our final section, we're shifting gears and moving into surgical interventions, the kind that can be absolutely life-changing for patients with certain GI diseases. This is ostomies and specialized care. The absolute foundational term you have to know here is stoma. In this context, it's an opening that's surgically created on the abdomen. It allows waste to leave the body, completely bypassing a part of the intestine that's diseased or damaged. Understanding what a stoma is the key to getting the next two terms. So the crucial question is where that stoma is created. A colostomy comes from the colon, the large intestine. An ileostomy comes from the ileum, which is the final part of the small intestine. And this difference in location is so critical because it completely changes the consistency of the waste. Just think, the colon's main job is to absorb water, so the output from an ileostomy is going to be much more liquid. That waste material we were just talking about, it's called effluent. And the person who is the absolute expert, the guide for patients who are learning to live with an ostomy, is the Wound, Ostomy, and Continence Nurse, or WOCN. This is a highly specialized nurse who provides care, education, and just incredible support. They are the ultimate ostomy experts. And that brings us right back to where we started. We have covered so much ground, from basic body functions to complex surgery. So, how does knowing all this vocabulary actually improve patient care? Well, when you master these terms, you can communicate with your team with precision, you can chart accurately, and maybe most importantly, you can empower your patients with knowledge. When everyone is speaking the same language, from the surgeon to the patient, care just gets safer and better for everyone. And that is why this all matters.